The broadcast is now starting. All attendees are in listen-only mode.
Hi there. We'd like to welcome everyone. We had a couple of technical difficulties, so I want to make sure everybody can hear me. Can you press the raise your hand button to make sure you're out there? There's a little raise your hand, a couple more. There we go. Okay, great. So everybody can hear us. So we're going to go ahead and get started, and sorry for the delay. First, I would like to thank everybody for joining today's Vital Nutrients webinar, which is entitled Integrative Management for GERD. Now, just a few logistics. We have everybody on mute, so the voice clarity is good. If you have questions, please just type them into your question screen, and we'll answer them at the end of the webinar. So for today's webinar, our presenter will be Dr. Beth Baldwin-Leon. Dr. Beth is a graduate of Bastyr University and has been a licensed naturopathic physician since 2004. In that time, she has worked in private practice, as well as in clinical research, natural product development, and the community clinics program at the National College of Natural Medicine. She is currently the Medical Affairs and Education Director for Vital Nutrients. So during this 1-hour webinar, Dr. Beth will discuss GERD, also known as gastroesophageal reflux disease. GERD currently affects about 20% of the U.S. population, and proton pump inhibitor drugs have become a widely used treatment that is readily available now over the counter. So while generally considered safe and effective in the short term, many people rely on PPIs long term in lieu of addressing the risk factors for GERD, including overweight and obesity and dietary habits and smoking. So in the past few years, numerous clinical trials have demonstrated an association between chronic use of proton pump inhibitor drugs and conditions ranging from dementia, osteoporosis, gastroenteritis, and colitis. So in this webinar, we will explore some of the drug-induced nutrient deficiencies associated with PPIs and how best to support patients in addressing their GERD symptoms with lifestyle, diet, nutritional, and botanical approaches. So with that, I would like to turn the presentation over to Dr. Beth.
Thank you, Sylvia. Can you hear me okay?
I can.
Okay, great. All right, good morning, everybody. Thank you so much for your patience as we sorted out a small technical glitch this morning. Thanks for the introduction, Sylvia. So I'm Dr. Beth Baldwin-Leon. I'm going to be presenting for you today, and I just want to first give the disclaimer that we always need to go through on our educational webinars, just stating that the information I'm going to provide for you today is intended for our licensed healthcare practitioners. It's for educational purposes only. We'll be making statements of nutritional support in the presentation that have not been evaluated by the FDA, and we don't intend for this information to replace diagnosis or treatment of any disease. Secondly, I also like to do a reminder for those of us who have been longtime customers, or for anyone new to Vital Nutrients, this may be new to you. I always want to emphasize what we do in terms of our quality assurance at Vital Nutrients, because it is really what the company was founded on and what makes us very unique. We do a lot of additional regulatory testing on all of our raw materials that come in. We test every single raw material that comes in, every batch, every single time, to make sure that it is not only what it says it is and as potent as it says it is, but also to test for a number of different environmental contaminants, and that includes 4 different heavy metals for all of our plant materials, chemical solvent residues, aflatoxins, which are mold toxins that can grow on plants in storage, hundreds of different herbicides, pesticides, and fungicides, as well as rancidity, PCBs, and dioxins for all of our oil products, and anything else that might be a particular vulnerability for that particular material. So we do all of that with third-party labs here in the U.S. We do not do skip lot testing, which would be allowed under the regulations. We've never done that, and we don't do it that way. We test everything every time. Every finished product gets tested as well, and we just don't rely on the certificate of analysis from our vendors, because we do know that mistakes can happen and it can be inaccurate. So that is really what makes Vital Nutrients unique, and as we go through the products within the presentation, as they do come up, I just want you to bear that in mind. So let's talk about GERD, what you came to hear about. And GERD, as Sylvia mentioned, is gastroesophageal reflux disease, basically defined as a condition that causes frequent heartburn. Heartburn occurs when our stomach contents, including acid, also as well as bile and peptin, which we're now finding are even a possibly bigger player in some of the manifestations of GERD. But the stomach contents flow backward into the esophagus. The symptoms can include what's described as heartburn or acid indigestion, that burning pain in the lower mid-chest behind the sternum. People can have a sour taste in the back of their mouth as they reflux that food and acid. Over time, they can develop hoarse voice or a loss of voice, chronic cough or sore throat. In extreme cases, they can have nausea and vomiting, and difficulty swallowing can be kind of a later manifestation of GERD or a complication of GERD that does warrant some additional investigation, which we'll talk about. So how common is this? We have now about almost half of Americans that experience heartburn at least once per month. That is not going to be a diagnosis of GERD. That is GER, so an episode of gastroesophageal reflux. It's considered infrequent or occasional. 20% of Americans experience heartburn at least once a week, still talking about an episode of gastroesophageal reflux there. Now, when people have more than 2 episodes per week, and this is becoming a frequent and chronic ongoing condition, then we can make a diagnosis of GERD, gastroesophageal reflux disease, and that is applicable for about 7 to 10% of our population currently. The lifetime risk of having GERD is 25 to 35%. I don't think that figure is corrected for the fact or accounts for the fact that it's very common in pregnancy. So if you think about the proportion of women who become pregnant and the proportion of those who will have GERD for some duration of pregnancy, I'm not sure if that figure encompasses all of those instances as well. So diagnosing GERD, it's most typically a clinical diagnosis just based on patient report, patient symptoms, patient subjective experience. If there's a question in the practitioner's mind or the patient's mind about the cause of their symptoms, it can be helpful and useful to do a 1 to 2 week course of 40 milligrams a day of omeprazole as a trial to see if they improve, and if they do, that is a pretty accurate way to diagnose GERD. It's about as accurate as doing a 24-hour pH monitor. If they need some additional workup, and we'll talk about why you might want to do that, but that type of evaluation you can refer out for endoscopy. It's usually the first starting point. Manometry can be performed where the pressure and the function of the lower esophageal sphincter can be assessed, and they can also do 24-hour pH monitoring if needed. So the people that we're going to be thinking about for sending out for further evaluation are our higher risk patients. They may be people with either dysphagia or odynophagia, meaning either difficult swallowing or painful swallowing, and they may need some extra imaging in terms of a barium swallow as well. People who have weight loss or early satiety or vomiting related to their GERD, that's going to be concerning. People with aspiration-related type symptoms like wheezing and cough, those will probably want to send them for further evaluation. GI bleeding or any unexplained iron deficiency anemia. Males over age 45 with long-standing GERD, these are the highest risk patients for developing Barrett's esophagus. So these are patients that we're going to have a little higher degree of sensitivity about sending out for more evaluation. Patients with a history of erosive gastritis, smokers, obese patients, and elderly patients we're going to be more sensitive to, because elderly patients can actually have fairly serious pathology that really just presents with mild heartburn. So a little bit more sensitivity to that population. You're going to want to do your appropriate rule-outs for your differential diagnosis for GERD, which might include angina, or even, if they have, if this is something they've not experienced before, you might even have a high degree of suspicion for an MI or a heart attack. Peptic ulcer disease, dyspepsia, which is another kind of a vaguer medical definition, but a type of indigestion that's different and separate from GERD, which is not as well defined. Cholelithiasis, so gallbladder involvement, gallstones. Esophageal achalasia, that's a rare condition involving the paralysis of the esophageal sphincter, and esophageal spasm, which is a episodic type of spasm of the esophagus. So the long-term complications of GERD, if it is left untreated, if it is not managed, the stomach acid that refluxes can gradually damage and change the cells of the esophagus. So esophagitis, inflammation of the esophagus, ulcerations can occur, strictures where scar tissue forms and narrows the esophagus. Swallowing can then become difficult or painful. And what most people are concerned about long-term is developing Barrett's esophagus, which is where the squamous mucosa of the distal esophagus close to the stomach is progressively replaced with metaplastic gastric epithelium. So the cells, stomach lining cells basically replace the esophagus cells. Barrett's esophagus is relatively rare, even in people with GERD. So most people who have GERD are not going to develop Barrett's esophagus, and most people with Barrett's esophagus are still not going to develop esophageal cancer, but it does raise their risk 30 to 125 times. Esophageal cancer is not very common. It's less than 1% of all cancers. It's about a 1 in 125 lifetime risk for a male, and about 1 in 435 for females. So it's not something that you're going to be seeing every day, but it is what we need to bear in mind when we're working with GERD. Other complications of GERD include in the airway. Asthma can result. We actually are now finding out very recently that pepsin is actually a big player here in terms of developing asthma, lung inflammation, infection, even fluid accumulation in the sinuses or the middle ear, in particular glue ear, which is otitis media with effusion and which can impact hearing temporarily. And we're finding out now that, it's not just the acid, it really is the pepsin that can be a big player on those. So prompt and effective treatment of GERD to the symptom management level is important, and bearing in mind that most patients, by the time they come and see you for GERD, they've typically been suffering with it for 1 to 3 years already. And maybe they started out with infrequent episodes of heartburn, and it gradually increased, and it's just kind of something they've been living with or managing on their own. So they've already been experiencing this probably for years before they really talk to you about it. And once they are into you, it's our job to make sure that we do get symptom relief within a reasonable period of time so that we can prevent these long-term complications. So GERD is something where once you make your treatment plan and agree on that with your patient, it's not a see you in 6 months. It's, come back in 4 weeks, let's reevaluate. If it's not really being well managed, we have a lot of other options that we can work with. Or you can decide at that point if you really do need to find out more and get some additional evaluation. So the causes of GERD, this has been a topic of debate actually for quite a long time. In fact, when I was in naturopathic school 12 to 15 years ago, there was kind of a question mark still in a lot of people's minds as whether the lower esophageal sphincter was even a sphincter. So it was kind of a debate that was going on. We do have pretty good evidence at this point that the primary cause of GERD is the transient relaxation of the lower esophageal sphincter, which does exist. It is not a true muscular ring sphincter, for instance, like the anus. We have a very clear structure there. This is a complex structure made of radial and longitudinal fibers. So it's a different type of sphincter, but this is the name, lower esophageal sphincter. And it's interesting because transient relaxation of the lower esophageal sphincter is just a normal physiological phenomenon that we all have up to about once an hour. So it's still not totally clear why people with GERD, why does this relaxation result in GERD in some people? Is it happening at inappropriate times? Is it happening for a longer duration of time? Is it happening more frequently? Is it just, possibly also that we have increased abdominal pressure for various reasons that's causing, during this transient relaxation, causing the stomach contents to reflux? So that part isn't totally elucidated, and it also might not be the same for all patients. It kind of might be a complex of different conditions. We do know a lot about the things that can relax or weaken the lower esophageal sphincter. There is a genetic component to that, so it can run in families. There are connective tissue disorders, including things like scleroderma. Pregnancy is a big double whammy because the high progesterone relaxes or weakens the LES, and then the large abdomen of pregnancy puts a lot of pressure on the stomach contents to reflux. So it's very, very common in pregnancy to have GERD. Smoking relaxes the LES. Certain medications do, including calcium channel blockers, morphine, beta agonists, alpha antagonists, anticholinergic drugs. Inhaled albuterol is actually on that list as well. And then there are refluxogenic foods, which either relax the LES, cause it to dilate more often or more, and they may also be more irritating when they do reflux out of the stomach. So that includes things like spicy or fried foods, acidic fruits and juices, peppermint, spearmint, chocolate, coffee, alcohol. You know, unfortunately, a lot of the things that people really enjoy might be aggravating their GERD. And usually people have a sense of what those are for them. It can be helpful if they really don't know or they're kind of in denial about it. It can be helpful to do an elimination and challenge type of diet with these foods in particular, and just avoid all of them for a period of time and then introduce one at a time and see if it really does trigger their GERD symptoms to return. And then we have the different factors that are increasing abdominal pressure. So that can include hiatal hernia, where a portion of the stomach has slid up through the esophageal hiatus of the diaphragm and is squeezing stomach contents into the esophagus. Obesity has become a very, very common cause of increased weight around the abdomen. Pregnancy, of course, we mentioned. Overeating, abdominal bloating or ascites, fluid in the abdomen, or even, you know, simple behavioral type lifestyle things like tight waistbands on clothing. You know, as people our culture becomes more and more overweight. We have, you know, 66% of people overweight in our culture. Potentially, those waistbands are getting tighter, just simply not helping patients not overlook the obvious things that might be contributing to their GERD. Lying down after meals is a really big one. So in other words, you know, possibly eating too close to bedtime, whether that's eating dinner or late night snacking. Lying down after that is going to be a risk factor for GERD. And then there's some aggravating factors that didn't quite fit into either of those categories, but when a person eats foods that they're sensitive to, and especially dairy, this seems to be problematic for, they can have either eosinophilic esophagitis, so basically an allergic type of GERD, or, you know, I find that people, when they eat foods they don't digest well, they just have a longer digestion time, they have more food stasis in the stomach. So it may be that, you know, even if they're not eating so close to bedtime, if they're eating things they don't digest well and then lying down, they've got kind of this stagnant food that may reflux back on them. And then emotional stress. We've thought of that a long time as being a contributor to GERD and heartburn and various digestive concerns. What it really seems to be doing in the case of GERD is it's like a lowered pain threshold. It's aggravating the perception of the symptom, especially. So it's not necessarily that it's causing the food reflux, but it's making that reflux more uncomfortable to the patient. And then in the past, and maybe in some people's minds currently, conventional medicine has considered that excessive stomach acid has been the primary problem in GERD. And it's a logical leap because the antacid medications, whether it's just antacids, the H2 blockers, the histamine 2 blockers, the proton pump inhibitors, they're very, very effective at relieving GERD symptoms. They do an exceptional job of it. So it's logical to conclude that the problem is the stomach acid, but the problem is not the stomach acid for most people. So for most people with GERD have been found to have about normal amounts of stomach acid, maybe very slightly elevated. There are definitely some patients who do hypersecrete hydrochloric acid. They may end up with refractory GERD, and, you know, in those patients it may end up that a long-term course of antacid drugs may be their best option, or surgery. But people, for instance, with Zollinger-Ellison syndrome, they have gastrin-secreting tumors of the pancreas or the duodenum, and they're just simply going to hypersecrete hydrochloric acid. this is rare, though. That's 1 in 1 million people per year. So in general, having too much stomach acid isn't the core problem. And then in naturopathic medicine, we have a theory that kind of went in the opposite extreme and proposed that most people with GERD had hypochlorhydria and that they didn't have enough stomach acid being produced, which is true for a lot of people in our country. A lot of people in our country don't have necessarily a good production of stomach acid. They may have hypochlorhydria, especially our older population with atrophic gastritis. This is a real phenomenon. But the theory about hypochlorhydria and GERD hasn't been well tested. The theory was that by not having enough stomach acid around, that they weren't getting enough of a feedback signal for the lower esophageal sphincter to close, and that therefore whatever contents were in the stomach were more likely to reflux. So it hasn't really been demonstrated in the research very well. It may be a player for some people. There are ways to assess. If you think your patient may have too much or too little stomach acid, there are ways to assess that. It's not a meaningful type of testing to do if they're taking antacid drugs or H2 blockers or AIs, because if they're on the drugs, they're going to have low stomach acid, and if they get off the drugs abruptly, they're going to have a rebound hyperacidity. So it's not really meaningful to do if they're already down that pathway of using the drugs. But it can be done. If you want to find out about your patient's stomach acid, there is testing for that. There's a Heidelberg radiotelemetry test where they swallow a tethered pH meter, and then a radio transmitter sends a signal about their pH, their stomach pH, to a monitor on a belt. And this is done after 8 hours of fasting. And then ideally, if you really want to be thorough about it, you administer a series of bicarbonate challenges and see if they can neutralize the bicarb. There's also a kind of a quick and dirtier type of version of this, which is a gastric acid string test. It's cheaper, it's not as accurate, you really can't do the bicarb challenges very well with that. It's basically a capsule on a string that you swallow, and it's essentially almost like a litmus paper that you attach the string outside your mouth. We did this in naturopathic school, and swallow it and measure the pH of the stomach in that way. But it's not giving as much information by a long shot as the Heidelberg radiotelemetry test. But if you do find that a patient has low stomach acid, there are ways to address that. So it can be addressed with using betaine HCl. We have the particular product that has the betaine HCl along with the pepsin and gentian. The pepsin is there because, remember, we need HCl in the stomach in order to cleave the pepsinogen that we make with the cheese cells to make the pepsin that breaks down our proteins. So this provides both betaine HCl, pepsin, and gentian. The HCl can help with maintaining a normal pH in the stomach, protein digestion, mineral absorption, B12 absorption, and then small intestine pH as well, because what comes down from the stomach really needs to be the proper acidity to trigger the buffering and the digestive enzyme release at the duodenum. And then the nice thing about this formula is the gentian root, which is a bitter herb, because we, in America, we are a country with a sweet tooth. We do not eat bitters. People, by and large, don't include bitter in their diet regularly. And bitter taste and bitter herbs and plants are what stimulate our own acid production and our bile flow, and they stimulate our appetite. And herbs like gentian have some anti-inflammatory properties as well. So we don't really do a good job of that in our society. We really are, we sweeten everything. You know, we do drink coffee. Coffee's bitter, but most people sweeten it, and that really neutralizes those properties. Most people don't care for the bitter greens like arugula, dandelion greens, even kale is a tough one for a lot of people. We don't have bitter melon like Asia uses. We don't use necessarily a lot of turmeric like India uses. So we don't have in our culture really, we don't really have a bitter tradition in our culture. So the bitter herb here, gentian, can help us restore some of our own acid production. This combination is contraindicated in acute gastric ulcer or gastritis, and really I would proceed very, very, very cautiously with a person with GERD with this, because if they do have that exposed mucosa, irritated, inflamed esophageal mucosa, they may, this may flare up their symptoms. even if you find that they are a candidate for, that they have hypochlorhydria and they could use some additional stomach acid. It still can be a really kind of a challenging type of treatment and one that I would proceed really carefully with. The recommended dosage that we have on this product is the 1 to 2 capsules at the start of the meal. Very important to take it at the start of the meal after the first couple of bites. You never want to use this at the end of a meal because you definitely will get some heartburn from that. There are some practitioners, traditional practitioners, that utilize a challenge test with this product to identify hypochlorhydria. That's going to be more subjective than doing any of the other type of testing. Again, it can aggravate their symptoms. It's something where, I'll let you read about it, but I'm letting you know because you may have patients coming in who've done a treatment like this or a testing protocol like this. So you may see some who have used HCl in this way. But it's basically something where the practitioner advises them to ramp up their dose of betaine HCl at the start of a meal and to look for a sensation of like heartburn, basically. So that's something that some of our practitioners undertake. Just interesting note, I've read that a healthy woman in a day can endogenously produce up to 60 grains of hydrochloric acid, and a healthy man can produce up to 80 grains per day. So I think that's interesting information, just something to keep in mind when you think about the dosing of what we're adding into the system. So unless they're making absolutely no hydrochloric acid, which is rare, I would just bear that in mind as we look at, we know that 2 capsules of the betaine HCl and pepsin and gentian contains 8 grains of hydrochloric acid. So just interesting information to keep in mind. So let's talk about what I would recommend in terms of integrative treatment of GERD. We're going to talk about strategies including lifestyle, nutrition, exercise, physical medicine to correct hiatal hernia. So that may mean visceral manipulation if you are a practitioner who does that or you know one to refer to. It can be really effective to use visceral manipulation to pull down the stomach into a more correct position where it's no longer sliding up through the diaphragm. There are also surgeries to correct that if it's an ongoing problem that the patient wants to have corrected. And there are also some exercises that patients can be prescribed. We learned about an exercise called heel drops to help them kind of dislodge a hiatal hernia and get the stomach to drop down into a lower position. Mind-body medicine, botanical medicine, pharmaceuticals as needed. We'll talk about them as a part of a strategy. They can be an effective and an appropriate measure when they're used short-term. Acupuncture. I'm not an acupuncturist, but in conjunction with PPIs, they found that acupuncture was more effective than just doubling the PPI dose. So really thinking about combining complementary strategies here rather than just hitting one over and over. So we have a lot of complementary strategies that we can combine for people. And then surgery as basically a last resort for patients that don't respond to other therapies. So the antacid medications, which have been the kind of core of the conventional treatment, these are some of the most widely prescribed drugs in the world, and particularly in the U.S. They're one of the most commonly used drugs that we have, and that includes the over-the-counter antacids, such as, for instance, Tums and Rolaids and those kind of things, which I would just caution you to. Some may contain aluminum, so that's something to be mindful of for patients. H2 blockers are histamine 2 receptor blockers, and those help decrease our production of hydrochloric acid as well. They do have some side effects, including for cimetidine. It's not that uncommon in men to have a side effect of gynecomastia when they use it for longer than 30 days. And with ranitidine, there's a risk of developing pneumonia, so among others. They're also not as effective as the proton pump inhibitors. The proton pump inhibitors have recently been shown to be more effective than the H2 blockers for relief of GERD symptoms. And they're really just shutting down the proton pump that helps us produce hydrochloric acid in the stomach. They work extremely well for what they are intended to do, which is to block the stomach acid. The problem with these medications is that they are blocking our stomach acid. So when they reduce our stomach acid in order to reduce esophageal irritation, it can be great for symptom relief, but it is not addressing the underlying cause of the LES dysfunction. It's not helping the patient to make any other changes to any of the contributing factors that are giving them GERD in the first place. Really, in a way, it kind of gives them a free pass to continue doing what they are already doing. And because they increase our gastric pH, they are interfering with our digestion. So of protein, of absorption of vitamins, absorption of minerals, and we're finding out more and more every day right now what conditions are being exacerbated by the use of PPIs. So there's a huge laundry list of conditions just since January of this year in the literature that have been associated with PPI use. So that includes increased risk of gastroenteritis, increased risk of colitis, of osteoporosis, not surprising since we know what this is doing to mineral absorption. Chronic kidney disease, now they were already associated with acute kidney injury in terms of acute interstitial nephritis, but this year they started to be associated as well with chronic kidney disease, dementia, neuroendocrine tumors. So these are not the benign drugs that people have, kind of so casually been writing for so many years, a couple of decades now. We've been using the PPIs just very indiscriminately, and they've even been made available over the counter. So this isn't completely news. We know that we've known for several years that the PPIs have been associated with low serum magnesium levels. So perhaps that's a mechanism of some of these problems. The FDA gave some guidance in 2011 about both the prescription PPIs as well as the over-the-counter PPIs reducing serum magnesium levels, and that practitioners should watch for hypomagnesemia and its possible serious adverse events, including tetany, arrhythmia, seizure. Generally, they noted that this hypomagnesemia would require magnesium supplements, but in 1/4 of the cases that they reviewed, that was not adequate to improve low serum magnesium levels, and the PPI had to be discontinued. So the recommendation at that time was that practitioners should obtain a baseline serum magnesium level prior to initiating PPIs, and then monitor magnesium regularly in these patients, which is, well and good if, number one, if it's being followed, and number two, if they're on a prescription PPI, but we already said, this applied to the over-the-counter as well. So it's out there for patients to buy and use without necessarily monitoring their magnesium level or being aware of that risk. We also know that long-term use of PPIs can deplete levels of vitamin B12 to a moderate degree that may require supplementation, and then other nutrients. The depletion level is kind of considered at this time clinically insignificant or clinical significance unknown. I think we may find out more about these depletions as we learn more about the mechanisms of the various conditions that we talked about with regard to PPIs. But depletion of folic acid, beta-carotene, vitamin C, calcium, chromium, which is important to blood sugar regulation, iron, zinc. And it's interesting because a lot of the same nutrients that PPIs can deplete are also the same ones that can be very healing to the tissues that are damaged from GERD. So it can set up a little bit of a vicious cycle there. So if PPIs are a problem, they work so well, but they've got a lot of risks associated. So we need to think about what else we can do, which is a lot. So in terms of lifestyle, if a person is a smoker, this is one more potential motivator for them to quit smoking. If a person has abdominal obesity, this is another part of the conversation about maintaining and managing their weight. Eating smaller meals can be helpful. Avoiding their aggravating foods, exercising moderately, not necessarily intensively. Intense exercise can actually aggravate GERD, and especially if it's done shortly after eating. Avoid eating within 3 hours of bedtime, practicing relaxation techniques. As we said, that emotional stress can be aggravating to the GERD symptoms. It's also a great idea to practice relaxation prior to eating, because that way we can eat more mindfully, more slowly, eat a more appropriate amount, potentially digest better if we're more parasympathetic and relaxed. And at night, when people are having symptoms at night, we consider raising the head of the bed. And I've seen 4 inches, I've seen 6 inches, I've seen 8 inches. This has to be done with blocks under the bedposts. It is not, if they have that type of bed where, I forget what they're called, almost like a hospital type of bed where they can raise the head of the bed, that's not the way to go about this, and adding pillows is not going to necessarily be very helpful for them, because anything that kind of puts them in a crunch type of position is going to increase their intra-abdominal pressure. So we still want the patient to lie flat on their mattress. We just want the head of the bed to be physically elevated. So it may be a negotiation if they share their bed with a partner. It may be a negotiation to be had there about how much of an incline is going to work for them, but it can be very, very helpful. Another helpful strategy at night, in particular if they do have trouble sleeping, but in any case, melatonin 3 milligrams daily at bedtime for 8 weeks has been shown to improve the symptoms of GERD, including heartburn and epigastric pain. Now, it does not on its own work as well as 20 milligrams of omeprazole. If you combine melatonin with omeprazole, that's actually even more effective. But if I'm treating a patient who also has insomnia and other sleep issues, they're going to get the benefits of some sleep support here, some potential relief for their GERD symptoms, some antioxidant support. So it's a multi-factorial kind of treatment. Nutritional supplementation that I'm going to think about, I want to, especially if they've been on PPIs, I'm going to want to replete some of those nutritional deficiencies that they may have been inducing. So in doing so, we might actually get some relief too, because calcium carbonate is effective as an antacid and reduces dyspepsia. We've known that for a long time. Magnesium as well can be very helpful. So those two together, especially at bedtime, can be very helpful for not just sleep and relaxation and muscle tension, but also potentially helpful for GERD symptoms themselves. Zinc is another one that can be depleted by PPIs as well. It does concentrate at the distal esophagus where it's close to the stomach. Serum levels do go down in patients that have reflux, and zinc can be very healing to the GI tissues. B vitamins also can help heal the damage. They may, though, need to be given intramuscularly for a period of time until their digestion improves. Some people may struggle to absorb those B vitamins. And so once some of these have been implemented with your patient, and if they are managed, if they are on a PPI and they are having good management, it may be time to consider taking them off of the medication if that is in your scope of practice. If it is in your scope of practice to prescribe the medication, then you can, and you've got the knowledge to do so, you can help them then taper off of the medication. If that is outside your scope of practice, then if they've been prescribed a PPI, you'll want to work with the prescriber or another prescribing physician in order to get off of that medication, so you don't get into an ethical gray area here. So I don't recommend taking patients off of medications if you're not licensed to prescribe them. But you can help them with these other measures, and you can certainly work integratively with their physician if need be. So what you'll want to do is implement the lifestyle and weight loss and nutrition measures first, and then we always want to taper a PPI, because there is a rebound acidity that occurs that can last 10 to 14 days. So this can be done, it may feel urgent. It may feel urgent to the patient to get off the PPI. If they've got, say, a family history of dementia and they just saw the research on PPIs and dementia and they just want to get off this thing immediately. We can appreciate that, but we want to do this in a way that's not going to send them completely into a downward spiral. So we need to do a taper. That taper can last 10 to 14 days or longer. If it's a higher dose of PPI, they may taper off over a period of a month. And during that time, what you can do is support them with botanical medicine. So you can either just put it in place along with the PPI, or you can, as you taper down on the PPI, do a reverse taper of the botanical medicine, so that you ramp down the dose of the PPI while you ramp up the dose of the botanical medicine, with the goal of maintaining their management and their maintaining their symptom-free state. So slippery elm is a good choice for that. The slippery elm bark powder is a demulcent herb. It's rich in mucilage and helps stimulate the production of mucus, which is the protective lining of the GI tract. We use a dose of 1 rounded teaspoon twice a day in water, juice, or another beverage. With the slippery elm bark, you can kind of make a little, like a slurry for that. They make a slurry that they can drink. So they can kind of play around with the consistency of that and see what they tolerate. The DGL powder is deglycerinated licorice. This is Glycyrrhiza glabra. Another demulcent herb. It does soothe and protect that irritated mucosa. It also promotes healing by stimulating the proliferation of the mucus-secreting cells. Our DGL at Vital Nutrients has no more than 0.6% of glycyrrhizin, so that we can avoid raising anybody's blood pressure with long-term use. That is why we use a deglycerinated licorice rather than just regular licorice. The recommended dosage here is 1/8 of a teaspoon 3 times a day after meals and at bedtime. Really take advantage of the bedtime dosing on these. Any of these powders, definitely do the bedtime dose, because that's a likely time that they're going to have reflux, and it's kind of perfect if they actually reflux this material, these treatments, into their damaged esophagus. It's actually kind of helpful. So Heartburn TX is another one. It's a combination formula that includes not only the deglycerinated licorice, but also zinc carnosine, L-glutamine, glycine, NAG, which is N-acetylglucosamine, and then aloe leaf. So this is a nice synergistic formula. It's meant to soothe and heal and strengthen that protective mucosa of the upper GI tract. We use a dose of 1 teaspoon 2 to 3 times daily as needed, and really remember to do that bedtime dose. We have the demulcent DGL. We have the L-glutamine, which is a fuel for the cells that line the GI tract, especially in the lower intestine, but it's just a very healing amino acid. NAG is a precursor to the GAG, glycosaminoglycan molecules of the GI tract. It supports mucous membrane healing and integrity. Glycine is, in animal studies, has been shown to be highly protective against acid esophagitis. It's also even sometimes included in over-the-counter antacids because it does neutralize a little bit the stomach pH. And then aloe vera is another demulcent mucilaginous herb that soothes and heals the mucous membranes and forms a protective coat to help with symptom relief. It has been shown to be safe and effective in reducing GERD symptoms in a syrup form, and it's also been shown to reduce gastric injury in an animal model of NSAID-induced gastritis. Zinc carnosine has done that as well. It's been shown to reduce drug-related side effects of taking a moderate dose of indomethacin, which is an NSAID. It's also an anti-ulcer type of treatment. So we've had wonderful testimonials and feedback on our Heartburn TX product. We've had patients that have been unable to sleep lying down due to their GERD symptoms, who've been reported back as symptom-free after 2 weeks of treatment, used as needed and at bedtime. I had one doctor had a patient with NSAID-induced gastritis who had a complete resolution of symptoms within a week. And Heartburn TX is often used by our practitioners when they are doing a PPI taper. So they'll advise the patient to reduce the PPI by even as little as 1 dose per week to avoid that rebound effect, and then use the Heartburn TX while they're doing that taper for up to 2 to 3 months. Turmeric is another herb that I just want to point out. There's an ongoing right now. They're doing a review of turmeric in the treatment of digestive disorders. It has been shown in the past to relieve symptoms of dyspepsia more effectively than placebo, and that included acid dyspepsia, what they called acid dyspepsia at the time. This study was a while ago. So it's not necessarily one that I'm going to jump on. It was 2 grams a day in 4 divided doses. So it's not necessarily that turmeric is going to be my go-to treatment for GERD, but when you have a patient coming in with multiple problems, which most of us have, if they're coming in for another type of inflammation, a knee, you know, a sports injury, whatever have you, I'm going to think about this as a time where, you know, using an NSAID for them, which they might already be doing, is potentially going to aggravate their GERD. The NSAIDs, as we know, they block the reuptake of the GAG molecules so that we actually have a harder time repairing our connective tissue when we're on NSAIDs, whereas turmeric is actually quite protective in that way. So if they can get some GERD relief potentially from the treatments they're also going to use for their inflammatory problem, that's a win. So that's where I'm going to consider the turmeric in particular. Mind-body medicine, again, like we said, stress and anxiety exacerbates GERD symptoms. There is some preliminary clinical research to suggest that symptoms can be improved by psychodynamic interpersonal therapy, cognitive psychotherapy, and relaxation training. So if you teach patients or recommend or refer patients to things like meditation or breathing exercises or journaling, anything that they may choose to help reduce their emotional stress can be helpful. And then finally, for patients that don't respond to other therapies, there is a surgical option for GERD. It's called a Nissen. The typically chosen procedure is the Nissen fundoplication. This is where the bottom of the stomach is surgically wrapped around the lower esophagus to create an area of high pressure and to prevent reflux of the stomach contents into the esophagus. So this is a surgery. It can be done laparoscopically, which is equally effective to having an open surgery, so would be, you know, ideally preferable for most patients. There's also a lower risk of hernia formation if they have it done laparoscopically, but there is a risk to the surgery of a higher incidence of swallowing difficulties than patients had when they used lifestyle and medical management. So it's something to bear in mind. And that brings us to the end of our presentation. I'm happy to try and address any questions that might have come up.
Okay, thanks so much, Beth. We do have some questions here, and if anybody has any more questions, now would be the time to send them in. But right near the beginning, it says, do you have any tips or ideas for managing EOE without the use of PPIs, assuming the patient has already eliminated foods they are reacting to?
So EOE meaning esophageal, or eosinophilic esophagitis, I think we're talking about?
Yes, I think so, yes.
Okay. You know, personally, I would probably think about things that I would use for other types of allergic manifestations like quercetin, something like our Allergy product. Some people do find can be helpful for different types of gastrointestinal manifestations of food sensitivities. So I would probably think about something like that. But did they say if they're not avoiding the foods, or they're, I mean, avoiding the foods is the key.
Has already eliminated the foods, yeah.
Okay, yeah. That's probably what would come to mind first.
Okay.
Yeah, I don't have anything else on that right now.
Okay. And then
I might think about that,
Okay. And then do you know where you can get a Heidelberg radio telemetry test done?
You know, they actually have a website of their own, the company that makes it. So as far as I know, I think you can just order it from them and conduct it. Or I'm not sure. You can find practitioners around you that are providing it.
Okay. And then I do believe you addressed this a little later in, but if somebody said, can you recommend a protocol for weaning a patient off the PPIs?
Yeah, and you can tailor that too. I mean, it's really about the patient comfort and the practitioner comfort. But you know, like I said, you're going to want to. You can take it as slowly as you want. It's not an emergency to get them off the PPI, even though they may feel very urgent about it. So you can really do it as slowly as they need to in order to try and maintain their comfort and not flare up their symptoms and flare up the inflammation of their esophagus. So, you know, as little as, you know, we have some practitioners that have used as little as reducing 1 dose per week over a period of months So you can do it as slowly as you need to while you implement the botanical measures and the other lifestyle pieces as well.
Okay. And then somewhere along in your presentation you said supplementation with magnesium was insufficient, quote. How much did they supplement and what form?
Oh, yeah,
and
good question.
Yeah, okay.
Good question. That was on the FDA guidance. So the website is there. There's a link to the FDA guidance. So they might say, but you know, that was probably their large observation of just how this was addressed by various providers. So it probably varied.
And do you remember, because they said in that same quote, 200 milligrams of mag citrate does not equal 200 milligrams of mag glycinate for blood level improvement. So obviously the elemental form is what they were, I think, implying. Do you know if it was citrate or glycinate?
That I don't know. One thing to bear in mind is about labeling. And so when you look at our labels, you'll see that they are giving the elemental amount of mineral. So it can be very confusing too when you're trying to make a protocol and you want a certain amount of magnesium. It can be hard to tell what's in there. So I just want to point that out, that on our labels in particular, you'll find the elemental amount of the mineral listed.
Okay. Okay, and Jess, if you're still on the line, somebody would like you to re-show that zinc carnosine slide. So as I'm talking through the questions, if you can go back to that, that would be great. But one of the other questions, which, if any of these, can be used in pregnancy, obviously?
You know, unfortunately, our hands are tied on speaking on using things in pregnancy. It's really a practitioner discretion, and there are, you know, good databases to refer to for data on pregnancy, but we're not really able to give that type of guidance. I'm sorry.
Yeah, yeah. And then what is your feeling about food sensitivity testing?
Yeah, you know, I kind of like food sensitivity testing. I mean, as far as lab testing, I have had good correlation between what I see clinically and what I experience with patients and their IgG food sensitivity testing in general. The gold standard for food sensitivity to me is the elimination and challenge diet, because if you're going to avoid something long-term, it's a lot more motivating to know what happens when you do eat it. So I think it's helpful for patients to sometimes do both, but I do think there's some value in doing food sensitivity blood testing or lab testing so that you can narrow down maybe what you're going to eliminate and challenge.
Okay. And then I don't know if you want to touch on this, but what is the suggested recommendations for Barrett's metaplasia?
The recommendation currently is long-term PPI treatment.
Okay.
In that case, because they are at the increased risk of esophageal cancer.
Okay. And a lot of people are asking, do you get a copy of the slides? We do post this up on our website after the webinar, and so you can listen to it as much as you'd like up there in lieu of actually providing actual slides. And we will do a little synopsis sent to you after the webinar as well. Okay. And then another question, Beth, heartburn TX dosing before, during, or after meal?
I like to do it after the meal when the reflux is likely to be most problematic, so that if they are having reflux, it's more the contents of the heartburn TX instead of their stomach acid and food. So I do it after meals and at bedtime.
Okay. Can you briefly explain why the addition of melatonin might help relieve symptoms of GERD?
I actually don't know if we know that. I don't know if we know the mechanism of that, but it is. It's been pretty well documented.
Okay. Would you try to wean patients off PPIs with known tissue changes in the esophagus? That's a tough one.
Yeah, that is a tough one. You know, that's going to be a very individual decision and a practitioner judgment call, but there is, you know, dysplasia that can happen in the esophagus prior to developing Barrett's esophagus. I probably, for myself, I would probably prefer to try and help them repair that tissue first and then proceed from there with weaning off the PPI, just for my own liability purposes, but you know, it's a judgment call.
Right. And then one more comment going back to that magnesium, you know, when I talked about the citrate, it says comment was more directed at the fact that some magnesiums are great laxatives, some are better absorbed into the blood. So I don't know if you want to go further into that or
I
not.
see what you're saying. Okay, yeah, I see what you're saying. Sorry, I didn't catch that the first time.
I didn't either.
Right. So yeah, the types that they specifically were talking about in terms of helping with GERD symptoms are the magnesium carbonate, the hydroxide, the oxide, the trisilicate. So yeah, so I would focus more on those forms then. I think glycinate would actually be probably a really nice pick. It tends to help the nervous system as well, so I think that could be a really nice way to kind of do two things at once.
Okay.
But yeah, citrate would probably be, you know, like my last pick for that purpose.
Okay. Okay. Well, great. Well, I think that is most of our questions, and I wanted to thank you for a great webinar. And we post this up on our website within 24, 48 hours, and we'll send you an email on that. And then we will also have some condensed notes for you that we'll send out. So thank you, everybody, for joining our webinar, and thanks, Dr. Beth, for a great presentation. Everybody
Thank you so much.
Day. Okay.
Have a great day. Okay. Bye-bye.